Welcome to the JOMA Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Welcome to the Jewish Orthodox Women's Medical Association, or JOMA podcast. I'm your host, Elisa Minkin. I'm a general pediatrician and proud JOMA member. And tonight I'm really honored and really excited to be speaking to Dr. Jennifer Weiss. Before I start, I'd like to remind people that if you have a topic you're interested in, comments, somebody you want to speak or you want to speak, please reach out to us at health@joma.org. I will also say that some of my podcasts are more geared towards healthcare professionals, and some are more geared towards lay people, and some are for both. I'm hoping both will listen to this one. It happens to be a little bit more medically, like a little bit more towards the healthcare professional end. But I hope that everybody can listen to it and learn from it. So Dr. Weiss is a board-certified pediatric rheumatologist. She graduated from St. George's University School of Medicine and completed a pediatric residency and fellowship in pediatric rheumatology at Schneider Children's Hospital, Long Island Jewish. She is board-certified in pediatric rheumatology. Dr. Weiss specializes in juvenile arthritis, Lyme arthritis, vasculitis, lupus, fever, autoinflammatory syndromes, and pediatric pain syndromes. Her research interests include clinical research on juvenile arthritis, chronic musculoskeletal pain, and quality improvement. She is a member of the American College of Rheumatology and serves on the Childhood Arthritis and Rheumatology Research Alliance Steering Committee and is vice chair of the CARRA, CARRA Pain Sub-Committee. She is also on the Pediatric Rheumatology Care and Outcome Improvement Network Steering Committee and has served on the New Jersey board of the Arthritis Foundation. She has served as site principal investigator on many clinical trials and quality improvement studies. Dr. Weiss is Associate Professor of Pediatrics at Hackensack Meridian School of Medicine and is a pediatric rheumatologist at the Joseph M. Sanzari Children's Hospital, which is part of the Hackensack Meridian Health System. Dr. Weiss's philosophy of care mirrors the mission and vision of Hackensack Meridian Health. She aims to listen to patients, make the correct diagnosis, and use shared decision-making to come up with a treatment plan. She says it is incredibly rewarding to help diagnose and treat patients with rare diseases so that they can live active, pain-free lives. Welcome, Dr. Weiss. Thank you so much for joining me tonight.
Thank you for having me.
Oh, I'm really, really excited. I've been waiting to talk to someone about pediatric pain disorder for a long time. I think it's a really important topic. I know that as a pediatrician, I have quite a number of patients with complex pain presentations, and I think you'll have a lot to teach us. I will say that of the disorders you see, I know you do Lyme-related disorders as well. That is a super big rabbit hole, controversial topic, and I'm going to leave it out tonight.
That's perfect, because I treat Lyme arthritis. I do not treat chronic Lyme. I don't consider myself a Lyme disease specialist or what. Yeah, I treat Lyme arthritis only.
Right. So I am scheduled to speak with a Lyme expert, particularly for neuropsychiatric Lyme, which I think is, a really complex topic. So let's start with just defining what is a pain syndrome and what are some of the most common ones you see in kids and teens.
So you could look at pain syndromes in different ways. There are patients who have inflammatory versus non-inflammatory pain. There are patients who have chronic pain that can be more diffuse or more localized. So I think for the purposes of this talk, you're probably interested in more of the chronic musculoskeletal pain syndrome, such as juvenile fibromyalgia. There's a lot of terms out there. If you search the internet or, read magazines, they might call juvenile fibromyalgia amplified musculoskeletal pain or chronic musculoskeletal pain syndrome or chronic widespread pain. So, I think it's confusing for practitioners, and you could see why patients, would be very confused when given one of these diagnoses. So I think we could look at AMPS, amplified musculoskeletal pain, as an umbrella term. And then under that, you can have the more sort of diffuse pain like juvenile fibromyalgia. And I think that makes up a large part of our practice. We see a lot of kids come in with pain, and most kids do not have inflammatory conditions like juvenile arthritis or lupus. Most of them have benign pain. I would say AMPS probably makes up, could be 10-15% of patient visits to pediatric rheumatologists across the country. And there is often a delay in getting these patients into the rheumatologist. So they might initially present to their pediatrician with complaints of fatigue or headache, or they may complaints of joint pain. They may be seen by ortho. Sometimes they're put in a boot, a brace or a cast, or told to rest. So that can actually make their symptoms worse, right? And then they may get some PT, and it could be many months by the time the patient comes to our office. And it might not even be that the provider was concerned about juvenile fibromyalgia, or that, they were even sending them for the pain. Like, these patients sometimes get over medicalized, or there's frequent trips to maybe urgent cares, emergency rooms, their pediatrician's office. So maybe they had labs done, and people like to order ANA tests. They think it's a screener for all rheumatic diseases. So the patient may come in with a positive ANA. Like, that might be why they were even sent to us, not even because there was concern for the diagnosis of juvenile fibromyalgia.
What is ANA?
Oh, so the ANA is anti-nuclear antibody, and it is a test that is used as a screening test if you're concerned that a patient may have systemic lupus erythematosus or mixed connective tissue disease. In patients with juvenile arthritis, if they have a positive ANA, they are at greater risk for developing uveitis. So they have a higher chance of getting inflammatory eye disease if their ANA is positive. But it is by no means a diagnosis of juvenile arthritis or lupus if you have a positive ANA.
Right. But it's not specific, and it's not uncommon to get a positive. That means absolutely nothing.
Oh, sure. 20% of the healthy population could have a positive ANA. You can have other autoimmune disease like thyroid disease and have a positive ANA. So it's certainly not specific or diagnostic. But oftentimes patients complaining of joint pain will have an ANA done. And so that might be a reason that they get in the door to see us.
I have a question for you. Would you prefer that the doctor not do the ANA first?
I would. Okay. I would prefer that.
I've just seen so many people get anxiety from it, and a lot of
yes, of course, which contributes, right? If you have, juvenile fibromyalgia and you've been suffering for many months, right? You're in pain and you're not sleeping well, and you may have headaches or belly aches, and then you go to the doctor and they do this lab test and you get a positive ANA, and they tell you might have lupus, which is usually what happens. Parents get super anxious and lose sleep. Then the kid, picks up on that, and they get very anxious, and it I don't think adds anything. Right.
So it might be better if you want to rule it out just to send straight to the rheumatologist. I know a lot of people want to be more independent and say, well, I'm going to do my own workup and only then will I send.
That's fine too. But I don't think an ANA needs to be done if you're not specifically concerned that they have lupus or mixed connective tissue disease, or
it's not a rule out, and there's a lot of false positives, so it's a confusing
right
to use on your own. It really needs to be used judiciously, I would say, right?
And there's also different ways to order it. So sometimes, whether you get an ELISA or you can just get the word positive, which isn't helpful, or you can get a titer, which maybe if it's a very high titer versus a low titer can be indicative of underlying systemic disease. Or so depending on how it's ordered, it also may not be particularly helpful or require then another blood draw, right? Because if you get the word positive, you don't know what that means. So you're going to have to order more testing.
Right. I want to go back a little bit on these terms we're throwing around: fibromyalgia, chronic amplified pain. I feel like there's more words for a similar thing than
right. And now we have, long COVID to sort of throw in there.
What are these chronic pain things that don't have specific? I would say these are all similar in that they don't have specific markers. Would that be an accurate way of lumping them together?
I mean, there's no one test that's diagnostic. So there's not a blood test or an X-ray. nothing like that I could order. There are criteria that are used to make the diagnosis. Most of what we know in juvenile fibromyalgia comes from the adult fibromyalgia literature. So there are ACR criteria that have been revised over the past 20 years several times. And so we've tried to adapt the adult criteria to the pediatric population. And so we are in the process of trying to get that tool validated. It's called the PSAT. And so that's a nice tool because the patient can mark on the body diagram where they're feeling pain, and then they can also check off any associated symptoms that they have. So hopefully that'll get validated and that'll make things easier. I think patients will feel more comfortable with the diagnosis if they know there's a more concrete way to make the diagnosis. I know you had asked me when we spoke earlier a little bit about, how you deal with patients when they say, oh, you're saying it's all in my head, or, right? So I think having this validated tool would really help with that.
Right. I think it's important to emphasize that just because a disorder doesn't have a marker doesn't mean it's not just as real. The pain is real. There's no question. There's no question.
And also, I don't have a marker for many things that I diagnose in rheumatology.
A marker.
Right. So I tell patients all the time, I don't know what causes it, but I can treat it, and I can't cure it, but I can put it into remission. So, it's still doable. And I think sometimes comparisons, like we don't know what causes lots of, diseases, but we can still treat them. So I just try to reassure them with that.
Right. So fibromyalgia, you mentioned that there's you have a diagram and they point to where there's pain points. What is fibromyalgia?
So it's a chronic pain syndrome. It's of unclear etiology. We're learning more and more. There could be some neuroinflammation from inflammatory cytokines. There are certain mediators that are elevated in patients with fibromyalgia. PET scans or functional MRIs also have shown different areas of the brain that might light up in patients with fibromyalgia. But we don't know what role all of these different sort of mechanisms are playing. But in general, we find that usually teenage females, there's some stressor. It could be a medical problem. It could be a social situation. It could be anything in life, right? It could be something that happens in the family, death, divorce. It could be your sort of overachieving female, gets straight A's, involved in a million clubs, or it could be a patient who maybe had been hospitalized or had something that sort of threw them off course, right? And then things sort of went downhill from there. So usually there's some sort of stressor and patients may start to feel pain. We know if you don't get a good night's sleep for a few nights in a row, you start to not feel well. And so these kids have some pain. Maybe they're not getting good sleep. Their pain starts to get worse. And what happens when someone complains of pain? You get told to rest. So they're resting. Maybe they're not going to school. Maybe they're not socializing. Maybe they've stopped doing their sport or whatever club or organization that they've been involved in. So they may be more isolated. It may affect their mood more, right? There is a strong association with anxiety and depression. So the joint pain really doesn't improve with rest, or if anything, they start to feel worse. They start napping, which makes it harder and harder to fall asleep at night, right? So their sleep gets more disordered. They have their pain. They may suffer other symptoms, headaches, irritable bowel type symptoms with bloating or abdominal pain. So, these are sort of the typical complaints I would guess we see in patients. And then on exam, they tend to not have arthritis or other signs suggestive of lupus, right? Their exam may be unremarkable except for pain with range of motion of their joints, or some patients who have more localized chronic pain syndromes, like what you might think of with reflex sympathetic dystrophy. They may have signs on exam like allodynia or hyperesthesia, or one extremity may be cooler than the other.
Those are long words. I have
Sorry.
and
Yes.
listening to this. Go back a little bit.
I'll separate it. Sorry. So I'll forget. We'll talk about those patients after, but these are more typically it's an adolescent female who comes in and has a lot of these complaints. So,
right. And what I'm hearing from you is that this is an adolescent female who has stressors, who may have anxiety and depression, and has no obvious, say, to a general pediatrician, findings on physical exam.
Yes.
And so
in fact, it could be the opposite, right? Sometimes there's this labile indifference, right? Where the patient's like, yes, I can't go to school, or I have so much pain, but they don't appear uncomfortable at all. But they will tell you their pain score is a 12 out of 10, but they don't appear to be a 12 out of 10.
So that's a real setup for it's all in your head.
Right. And because they've already, by the time they've gone to the rheumatologist, probably have seen several doctors, and so, they don't really feel, validated, right? They don't think you believe them. And I tell them, I do believe you. And I think that, it's usually been a few months for them to get in to the rheumatologist. And I say, it's going to take a few months maybe for you to feel better. I don't have one thing to give you right now. So I talk to them about what we need to do to get better. And I tell them it's not easy. And some patients are able to do it. Some patients, need assistance. Some patients go into like day programs or inpatient programs because they need more support, and that's fine, right? Doesn't matter how you get there as long as you get there at the end.
When you say day programs, you mean these are kids who can't go to school? They can't do the day-to-day functioning because of the pain? They
can't do the day-to-day functioning, and the parent really can't get them to do it either. So if you have a patient that really can't do it, can't get to PT, or, I sometimes refer patients to a pediatric pain specialist, and there's different schools of thought on whether or not medication should be used. But I do think that sometimes kids need something to help them sort of get over that hump, right? Mm-hmm. So if they have to be on Neurontin or Lyrica or Cymbalta or some of the other SSRIs, and that helps with their mood and their energy level, and it helps control pain and allows them to actively participate in physical therapy or some schooling or some extracurricular activities, then I think we should do it. They don't have to be on it forever. Mm-hmm. And I tell parents it's not a narcotic pain reliever. Right. They're not going to be addicted. It's just to help them engage in their physical therapy.
What's the role of mental health issues like anxiety and depression in these disorders?
I think it could play a big part. Mm-hmm. Some patients may come in already with those diagnoses, and some may not, or some may say they don't feel anxious, or they don't feel depressed, or maybe the patient does, but the parent's not aware, right? It's not unusual that you find like a kid's been cutting. Like we put all patients in shorts because we want to examine their legs, right? We need to see their knees. And so if they've been cutting their inner thigh, like parents may not even be aware. Wow. So I think there's sort of all levels.
What I'm asking is it a chicken or egg thing, right? I mean,
yeah.
Because it's super sensitive, because of course, the first thing you have to say is it's not all in your head. I believe that you are suffering. It's not that you have mental health problems and it's not real. It is real.
Oh, I say the opposite. I say it is in your head because your brain is in your head, and all of your pain, pathways, they're sensitive. Everything's being amplified. Your pain is being amplified in your brain, and so that sort of maybe breaks the ice a little, or I get a little chuckle out of the patient, right? That's where your brain is, right? It's your peripheral nerves, your central nervous system. So, but I say, yeah, I believe you're having the pain, but it's in your head.
Right. What I'm right. Yes. Good. I had a similar conversation with the head of the pediatric IBS program. I believe it's at Boston Children's. Mm-hmm. A really very similar paradigm, right? That the mind and body are connected, the brain gut, the brain body. It's all connected. Mm-hmm. But I find with these patients that I have to work to bend over backwards to say that I believe that there's something going on with them that's real, that the pain is real, that I find it hard sometimes to deal with the anxiety and depression that's so comorbid, that goes along with it so frequently. And almost it doesn't matter which causes which, because I think they both have to be dealt with.
Right. I don't know that it's which causes which, but it's just how are they going to be treated?
Right.
So some kids may already be involved in therapy or be on medication. And sometimes I will ask, because I just find not every therapist necessarily asks a patient or client, about pain. Like they may talk with them about their sleep, or they may talk about, issues in the family or home, but they might not ask the kid if they're in pain. And the kids don't think to mention it to their therapist because they don't think that's what their therapist is for. So I think that's like a really important point. And I try to tell, like, if I meet a therapist or a social worker, ask about pain, because relaxation exercises, meditation, cognitive behavioral therapy, all of that stuff can help with pain, not just, anxiety, right? So I think there's so much interplay. I think cognitive behavioral therapy is so important for chronic pain, for IBS, right? But it's so hard for patients to find.
Right. Not all therapy is CBT. That's the problem.
Right. And then let alone someone who does CBT who takes insurance.
Right.
It's really hard. So there are some online resources, but I think that that's a real challenge. But if patients are already hooked up, that's great. And sometimes I give them the names of the other, like of Cymbalta, or, and I say, talk to your psychiatrist. Maybe it's a change that could help with your, anxiety, but also help you with pain. So, sometimes, it's a more cohesive sort of unit. Sometimes I have to call our social worker from the hospital, who could then try and arrange services locally for the patient. We see patients from a large catchment area. Mm-hmm. So I'm not always familiar with people in all parts of New Jersey. And again, it's a challenge if patients don't really have mental health benefits with their insurance, because it's very expensive to pay out of pocket.
Right. That's unfortunately another barrier to care, is that when you mention mental health and they're thinking, but I have to pay for this, which shouldn't be, but it is.
It is. Right.
That's a huge barrier. But it's interesting that you're saying that the medications that could help the physical pain could also help the mental health. I wonder if you frame it more one way than the other, that would help.
It depends if they're on something. So I don't know, routinely, I think kids are on maybe Zoloft or Prozac, maybe Effects or Lexapro. Like some of those can help with pain, but I also mentioned Cymbalta. Or
is in which category?
Sorry, duloxetine. It's an SNRI.
NRI. Mm-hmm.
Yeah, and then Neurontin and Lyrica are, also available. So some people are okay with medicine. Some people are not okay with medicine in general. So, that could be harder. So then I'll refer sometimes to the pain doctor, because I think that they may have other options, or maybe the patient hearing it from someone else is helpful. Like they've had some time to digest what I've said and can then talk about it.
Real question here. I wonder if you ever work with alternative practitioners.
I don't sense any, I don't have any special relationship with anyone, but I've certainly seen patients who have worked with functional medicine doctors or.
But does your hospital have? Because you're part of this.
Oh, no.
Oh.
No, we don't actually. Not that I know of.
Because I'm wondering what the role could be in these kind of disorders. I'm just wondering.
Right. I mean, I think there probably could be some role, but I think, I don't know, a lot of the functional medicine people also don't take insurance.
Mm-hmm, that's true.
Right. So.
Yeah. Right. And functional medicine is one category. I mean, I'm thinking of just some holistic practitioner who might be able to spend more time and have various non-medication alternatives that may engage the mind body, because this is such a mind body.
I mean, I tell people they could try acupuncture if they want. Like some people have an interest in acupuncture, and I say try it. Like if they want to do something like that, I think it can certainly potentially offer benefit. I always recommend yoga, Tai Chi. There have been clinical trials looking at Tai Chi for pain relief. Mm-hmm. But kids don't have so much of an interest in it. So I'm like, do what you love, right? So if you're I'm never going to do yoga, let's not go on about yoga. You're not going to do it. So
so we're not going to keep pushing it.
Right.
So back to the physical therapy.
Mhm.
What is recommended? We're still talking specifically about juvenile fibromyalgia. What is that physical therapy for that?
So I often recommend that patients stay here at our hospital for PT, which isn't always an option. But I think that if you just walk into any PT place in a shopping center and you're like 15-year-old, I don't know how well you're like the program's going to go for you, you know? So I think here they're used to working with pediatric patients, and they've seen a lot of patients with juvenile fibromyalgia. I usually recommend sort of a graded exercise program. I mean, I tell patients all the time, like if you go out and you're a weekend warrior, you're going to feel so bad for a week or two after, you're not going to want to exercise again. So I think if they could start slow, they could do stretching videos. They could do the yoga if they want, or Pilates. They could ride a bike, swim this time of year. Those would be all great things to do. Walk the dog, walk the neighbor's dog.
Graded meaning that
start out slow.
Start out slow and go slow. And if you feel worse, then stop.
Yeah, you push yourself a little bit, but if you just are like, I'm going to go run that 5K and you haven't run in months, you're going to feel really sore after you do that 5K, right? Or you just pick up 20-pound weights, it's going to hurt. And then you're going to feel terrible and you're not going to want to go back to do it. So I think you have to have a more graded exercise approach. And I do give patients like some information about exercise and different sites that, that they can try, or I tell them to enlist a friend or go back to soccer, even if you don't feel like you can play. Like they'll be like, I can't play, but I'm like, it's okay. Go sit on the bench, see your friends, right? The camaraderie is important. Maybe you do the warm-ups with your team and then you don't play. And then maybe you stretch at the end with them, and right? But just get out there, get back.
Right, get out there, but know your limits.
Right.
Right. And the reason I'm focused on this is because my understanding is for a lot of these syndromes, they were saying that it was best to push through pain, and the pain is something you should be ignoring, and having the PT being very intensive and not individualized. Is that correct?
No, I would say I think you, yes, have to push yourself, because I do tell them it's going to hurt. Like it is going to hurt, but you still have to try and move. But like I just try to use the weekend warrior analogy, like you have to push yourself. If you don't push yourself, I think you're really going to have a hard time getting better. And I think those kids that have a hard time pushing themselves end up in the day programs or the inpatient programs, because it gets really problematic. Like the kid's in pain, the parent doesn't know how to handle it, or there could be a lot of enmeshment, between maybe the mom and the patient. And sometimes just having the patient go to a day program and there's some place for several hours where there's a routine where they have to participate. Usually those programs will incorporate mental health, so that could be very advantageous for some patients.
Right. I mean, I've definitely seen this where there's anxiety on the part of the parents that their child is experiencing pain, and the child is staying home, not going to school, avoiding that. I can totally see that. And I've definitely seen that, in my pediatric career. In fact, I had a particular situation where I was very involved with the school, making sure the child was in school. At least it was in the library for part of the day. He
right.
Out. So yes, on the one hand, you could be so extreme where you could be avoiding, and that would amplify. We didn't get to amplify pain, but it would amplify it. But what I'm trying to emphasize is on the other side, I think that there has been pressure from the same people that do the amplified pain programs, right? To say, well, the only way that you can get past this is to push through the pain. And I think that patients, I know adult patients have said this, that it's been hurtful to them because they needed to do what was right for them. You know what I'm saying? There's a middle ground.
Right.
Right? Am I right about this?
No, and I think that, right. I think that's why I think it depends on the patient, and also what was their level of physical activity before, right? So I think everyone sort of has different limits. Some kids may have been very fit and maybe haven't been doing much just for a few weeks, whereas maybe there's kids who never really did much, right? And it might be harder for them, or maybe a kid was hospitalized with some illness or something, like became really deconditioned, so I think it's different for everyone, for sure.
Right. So now I want to talk a little bit about, we keep mentioning chronic amplified pain. That is not the same as juvenile fibromyalgia.
Well, you can look at it as like amplified musculoskeletal pain syndromes as maybe the umbrella term, and you can have juvenile fibromyalgia, which is more of a chronic diffuse pain.
Mm-hmm.
Some patients have a more localized pain. So the typical example would be maybe a kid who did have an ankle sprain or a fracture or something and was in a cast in a boot for a while. And so they weren't really moving the extremity much. And they can get also an altered sensation where they have a lot of pain. And then the orthopedist, let's say if it was an orthopedic case, thinks it's maybe from the fracture that hasn't healed or the sprain, so that their time in the boot, let's say, or immobilized gets extended, which can make the symptoms worse. So their pain sort of gets amplified. And when you look at those kids, on exam, if they were wearing a boot on their left ankle for 12 weeks, that extremity can be cooler than the right. They may be very sensitive even to just light touch, and then, have pain with range of motion or an exaggerated pain response. These kids, if you ask in the history, they could tell you that like maybe even the shower water hitting their leg is painful. Putting on their sock, the bedspread on their leg is uncomfortable. And so those kids need also physical therapy and desensitization. And that's really challenging too, because that does really hurt them. And so those kids certainly really have to push hard to get through it.
Right, but how hard, right? I mean, I have definitely heard people say that they've been asked to push too hard. What's too hard?
I don't know that I could say I don't know. I think, right?
The reason I'm pointing this out is like my understanding of these syndromes is that your brain is telling, it's like a car alarm that's going off that shouldn't be going off, and you got to desensitize to it to turn it off.
Right. So there's different things to do, right? So you can do like, you can put your foot back and forth between the lukewarm bath and a cool water bath, or you can take a towel and shimmy it up and down your leg and things like that, which are going to be uncomfortable for sure. But then maybe weight bearing, range of motion, exercises maybe are more painful for that patient. And so at least, I don't know, I try to get my child life therapist involved with the patient, right? Because it is going to be painful. So what can you do in that moment to help with your pain? So whether it's giving them a stress ball or showing them different relaxation apps that they could use, or coming up with a reward system, whatever the strategy is, like it's going to hurt, right? But we can get through it, and then you'll be better,
Is there a role for medications with those kids?
I think physicians that would use those medications may consider it for these patients as well. And I think there are some people that don't think there is a role. So I think it's individualized.
Mm-hmm, mm-hmm. How is chronic fatigue syndrome different from fibromyalgia?
Oh, well, I guess it depends maybe a little bit of if there was, preceding EBV or infection. I don't want to say I don't see chronic fatigue syndrome, but because I probably do see it, but it's not, I don't go through the checklist of, criteria for chronic fatigue when I'm seeing a patient. So I think those patients probably present similarly and are treated similarly.
Do they not come to you? I mean, I certainly have seen patients over the years with chronic fatigue, and now we're seeing so many more with a similar syndrome, long COVID.
Right. So I think sometimes chronic fatigue patients were sent to ID because of the association of EBV. So I'm not sure. And now we are seeing a lot of patients with, let's say, long hauler syndrome, long COVID, which could be similar to chronic fatigue and to fibromyalgia. A lot of our approach to treating them is the same. I think with regards to the activity, sleep hygiene, that sort of thing.
Okay, when it comes to long COVID / chronic fatigue, because I really do think that they're really very similar, just triggering things.
Sure.
What would that look like in a patient? It's not just pain, like fibromyalgia.
Oh, the patient would look the same. I think it's more I had COVID. or I didn't have COVID.
So in addition to pain, right, they would also have
Fatigue, headaches, sleep disturbance. They could have dysautonomia, anxiety, depression, brain fog.
Brain fog. Okay, we haven't talked about brain fog yet. And when you say dysautonomia, what do you mean by that?
Like POTS.
Mm-hmm.
They don't have to fulfill criteria for POTS completely, but the headaches, dizziness, tachycardia or palpitation. Oh, postural orthostatic tachycardia syndrome.
Mm-hmm.
So patients typically will just say they feel really dizzy and have headaches, and they may report also palpitations. And we're seeing I feel like I'm seeing more of that in practice than I've seen in a long time. I mean, sometimes we would get referrals for POTS, and I think no one quite owns POTS, and no one really wants to own POTS maybe. So like patients maybe will see the cardiologist and their echo is normal, but I don't think patients with POTS necessarily have long-term follow-up, or right. So they might also sort of bounce around a little bit between different specialists. So I think we've been seeing more of that lately in our long hauler clinic, kids with those symptoms of dysautonomia.
So you're seeing these primarily after COVID now?
Me personally, yes.
But
it's been out there.
Maybe there's more of them from other reasons too?
Sure.
And so these are kids who have a greater tendency to feel like they're going to pass out?
Yeah, some do pass out.
Mm-hmm.
Some, just feel very dizzy, so they can't do their sports, can't go to school, or, home in bed. And it's hard. It's a lot, fluids to drink. Some kids will get a low dose of steroids. And so they certainly can be treated.
And they're also supposed to have some kind of physical therapy program?
Yeah, and they go for, yes, they go for PT too.
So, I mean, it all seems to be like different flavors of the same thing here.
Yes, that's a good way to put it.
Yeah, I also want to talk about hypermobile EDS.
Yeah, that's another thing I feel like no one really quite owns it. So I think before I really started working so much with pain patients or had an interest in pain, I looked at the EDS patients coming to rheumatology, maybe to exclude arthritis, right? Make sure nothing else was going on with their joints. And, a lot of times patients who have the diagnosis may have already been through physical therapy or have a physical therapist that they can go back to as needed type of thing. So, but now I sort of am more aware of the association with chronic pain, and also try to validate what these kids are feeling.
Right. I just want to go back a little bit and say what EDS is.
Ehlers-Danlos?
Yeah, because we didn't define it.
Sorry. So there's hypermobile EDS, which we don't have a genetic marker for. So I think the other types of EDS, if they have vascular disease, they see genetics, they get diagnosed. And I mean, those aren't patients that I routinely see, so can't speak totally to their course. But in rheumatology, I think we get a lot of the hypermobile EDS patients who may or may not really have the diagnosis. It may be that they're sending them to rheumatology to make that diagnosis, or there may be kids that have the diagnosis and who have a lot of joint pain, so they get sent to rheumatology.
So what are the criteria for hypermobile EDS?
Oh, well, I don't know if I'm going to say them all off the top of my head exactly, but, they're very flexible. So if and I won't be able to show you well with but if you go like this, the tip of your thumb sticks out this.
Hyperextensible, right?
You're hypermobile, but there's different maneuvers. So the thumb sticks out. I can actually do this one. You can do the bend your thumb. There's just hypermobility, and then there's EDS, and we see kids with hypermobility all the time, like little kids who are very flexible, who just have a lot of joint pain, or sometimes again, if pediatricians are concerned about EDS or Marfan's, they may send them to rheumatology. So it's sort of, I think it's like a spectrum, right, of what we may see. We certainly see kids with benign hypermobility syndrome. They may or may not have chronic pain. And then we do see some patients who actually meet criteria for hypermobile Ehlers-Danlos syndrome, and they also may have chronic pain. And I think in those patients who have EDS or who may be very disabled or really be suffering from pain, I think it's very important for them to see the physiatrist, to see if there's any devices, splints, things like that, that may be helpful. And they also need physical therapy to help maintain their joints and their muscles. I think the group of hypermobile patients who we see who are very young, we tell them, maybe they need a shoe insert, maybe they just need a good sneaker and not wearing flip-flops all day, and they're fine. And then there might be those kids in between who need some PT, but don't necessarily need to see the physiatrist or don't really suffer from chronic pain.
So in addition to hypermobile joints and chronic joint pain, what else do the hypermobile EDS patients have?
On exam, there might be changes in their skin, like they can have like velvety type skin, mm-hmm. They could scar. I always look at, their palate, like, because again, thinking about Marfan's, like, do they have a high arched palate? I'll send them to the ophthalmologist to get screened for like things like retinal detachment if I'm concerned, the hypermobility, the scarring, velvety skin.
Do they also have a high rate of anxiety and depression like all the other populations we're talking about?
I wouldn't be surprised, but I don't know that for sure. It's really not a big part of what I
You don't do that much of the hypermobile because, yeah.
I mean, I see kids with hypermobility, but specific patients with EDS is far less.
Is it uncommon? Because I keep hearing about it. Like it's the most common thing since sliced bread.
Well, I think that's like where I say like no one really owns the diagnosis. Like I think too, or you have to go see genetics, right, and get screened, and I think they see a lot of subspecialists, but I don't know who the gatekeeper is exactly. So since I'm more aware of that, I try to now be more of a gatekeeper a little bit. But I think it could be challenging.
Mm-hmm. It's probably something that's both under and overdiagnosed.
Right.
Right. And, the problem with all of these disorders from the perspective of the generalist, right? Like on the generalist, is that we're seeing someone without markers with vague, pain, and they may not show anything physically, and they may have mental health problems. So I'm just,
Well, for juvenile fibromyalgia, yes. For hypermobile EDS, they're going to have exam changes. Like you just have to sort of go through like the checklist. Like there's a like Beighton score. You do all the signs for hypermobility. They've forward flexion. Can they put their hands flat on the floor? Do they have pes planus? Like there's different. So it takes time, and so there might be generalists that say, "Oh, you're really flexible. Let me have you go see the rheumatologist to make the diagnosis," or they might just send the patient to the geneticist to make the diagnosis, or they might just send them to the cardiologist.
Right, or they might just dismiss them as making it up and having it all in their head.
Or they might just dismiss.
That's what I'm getting at. I think a lot of generalists just think, oh, there's the latest diagnosis, the diagnosis du jour, and they don't understand that these are real disorders. And then there is the problem of overdiagnosis too, where somebody who doesn't have expertise just says, oh, I know what you have hypermobile EDS, and then there's no marker to prove or disprove.
Right.
So, I think that can be a problem. And I actually did read somewhere, I would have to look it up, don't quote me on this either, that there is an increased association of anxiety and depression in the hypermobile EDS.
It would make sense. It would certainly make sense, right? Because yes, they could have chronic pain. Mm-hmm. There's certainly reason to be a little bit anxious when you're not feeling well, right? If you can't do everything you want to do, if, some schools like don't even have elevators if kids need, or they're, so like it's hard. And if you don't have the services available to you, I think it could be pretty stressful.
Right. And I think that a lesson for any clinician, though, is, and you've mentioned this before, is just validate.
Mm-hmm.
Right. It's not hard to just take them at face value and say, this is, what's hard for you and how can I help?
Right.
Right. You do have a long COVID clinic, right?
Mm-hmm.
That you're part of. I'd like to hear more about that because I keep talking about multidisciplinary clinics because one thing you've kind of been alluding to is a patient can be bounced from specialty to specialty, especially with no one taking ownership.
Right.
Looking at that one, system.
So we started our post-COVID clinic a little over a year ago, and initially it wasn't specific for long haulers. It was any patient who had COVID, because where my hospital is located, we're right outside of New York City, and there was a lot of COVID cases here, and a lot of kids were admitted with COVID and with MIS-C.
Mm-hmm.
So we were seeing these patients for follow-up, and so we established this clinic. It's run by myself and Dr. Katie Klauser, who's one of our hospitalists. And so we would see the kids after they've been discharged to monitor their lab results, taper them off prednisone, make sure they were getting their follow-ups, because a lot of the kids who came in with MIS-C were treated like Kawasaki disease patients, so they might have been discharged from the hospital on aspirin or steroids, need to see the cardiologist. So we were sort of managing all of this.
This is that scary inflammatory syndrome that we saw in the very beginning that we discussed before that, thank God, we're just not seeing.
Right. So yes, thank God.
Yeah.
This was very scary. Yeah. So that's sort of how it started. And then now over time, it's really become more of a long COVID clinic where we see a lot of patients who, following their COVID infection, have the symptoms of fatigue, pain, headaches, brain fog, maybe the dysautonomia. And so every patient is seen by myself and Dr. Klauser. Some patients, depending on what their complaints are, may at the same time be seen by the neurologist if they're having bad headaches. A lot of kids will have dyspnea on exertion, and they may see the pulmonologist and get PFTs. And if they're complaining of palpitations, we get them into the cardiologist. So we try to coordinate so that the patient's just coming to the medical center once. And then we do have social work and child life therapists that are available depending on what the patient's needs are. So we get them involved. And then most patients, I would say, get a prescription for physical therapy at the visit.
Do you also work with the schools?
If we need to, we do. I mean, we do that anyway in our day-to-day practice. So it's not so hard, but I won't just take a patient out of school. I won't put them on home instruction. I will certainly work with them, whether they go back, if they've been out a while. I get it. It's scary. Go back for a half day, go back for lunch, go, depending on the age of the kid, go for lunch and recess, go for your art class lunch and recess, like whatever it is, because I want them to socialize. I want them to get back into a routine. I want them to get up in the morning. So we will work with the schools to get them back in.
Did you say you also have mental health as part of that multidisciplinary team? Social
work and child life therapists. We don't have a psychiatrist. I don't have a psychiatrist. We have a pediatric pain doctor, and as part of her team, she has a nurse practitioner that works with her, and also social work and child life. So, but I don't have a psychiatrist as part of my program.
Do some of the patients get recommended to go elsewhere for that piece?
Yes.
I just want to spend a minute or two more explaining why it could happen that what happens when a child is kept out of school due to their pain. So I think we kind of alluded to it without really going down that path more clearly.
Well, so it's important to go to school for many reasons, right? Their education being one of them, but there's also the socialization. And I think and I say this to kids all the time, if you're not getting up to go to school and you're just laying in your bed all day, come 10 o'clock at night, you're not going to just fall asleep after you've been laying in that bed all day. So it's really important to have a routine to move and expend some energy so that you're tired later. And I think the camaraderie is important. And I think the longer they stay out, the harder it is to get back into school. And we saw with the pandemic, right? Like a lot of it, I don't know that it's right. from the COVID virus actually infecting the child, but just from the pandemic, right? We've seen patients who have lost a parent or another loved one, or patients whose schools were closed for extended periods of time. And then some schools gave the option of home versus in-school instruction, and people stuck with home instruction. And if you haven't been in school in 2.5 years, it is really hard and scary to go back to school, so we just try and come up with a plan to get the kid back in and try and make life as normal as possible.
I'm finding, I don't know what you're seeing, but I'm finding that parental anxiety is through the roof.
Yeah.
Through the roof, right? I have parents who've kept their kids home for longer because they were afraid of COVID. Mm-hmm. And then you have that interplay. So like in my ideal world, I would have family counseling as part of that. I don't know if you have that. Or you need that, but
but no, we don't have that. I mean, it's just so hard, but
I want everything.
Oh, believe me, I want everything too. Right. But yeah, I mean, which I think sometimes is why also that we need those inpatient programs, like, right? Because if the mom is so anxious, sometimes you need a little bit of that separation, right? Because I think if your family's really anxious or stressed, like it just can affect everyone.
Everybody feeds off everybody else. Mm-hmm. Yeah. No, that's really, really helpful. I feel like we actually covered a wide range of pediatric pain topics. Anything else you want to add here?
No, this has been great. This hour went really fast, but if happy to see anyone's patient with chronic pain, or if they're not sure what's going on, I'm happy to see them in the office. So we're here.
Yeah, tell us where we can find you, please.
Oh, so I see patients at Hackensack Hospital in one of the outpatient buildings. We're in Hackensack, New Jersey. So we're right over the George Washington Bridge. We do telehealth visits, but they have to be in state. Mm-hmm. So it depends where people are located. But we have a large group of pediatric rheumatologists here. So I see most of the kids with chronic pain, but certainly we're all available.
Now, I think this is so helpful. And I want to thank you so much for doing this with me.
Thank you. It's been great. It's nice meeting you.
You too. Thank you so much.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOMA_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.